Hello, I'm Will McConnell. I'm one of the respiratory consultants at Dorset County Hospital. I'm also the clinical lead for the Dorset Respiratory Network and also one of the clinical leads for the Southwest Respiratory Network. And I wanted to talk to you about the new asthma treatment guideline that is due to be released in November 2024. And this is a major change to the way we manage asthma in the long term, and it has an impact wherever asthma treatments are started. So that will affect GPs, practice nurses, emergency departments, and people involved in the delivery of acute medicine. So the reason that there's being this change is because there's new evidence about how we can have an impact on the fact that a lot of people still die of asthma, and asthma deaths are preventable. And we've known this for a long time. The National Review of Asthma Deaths was published in 2014 and highlighted how many people were dying unnecessarily in Britain from asthma. And they reviewed this report a couple of years ago and found that nothing had changed. The UK, as we can see from this chart, has the worst mortality rates for asthma in Western Europe, and we sit alongside Turkmenistan, Georgia, Macedonia in terms of our mortality rates. And the crucial thing is these deaths don't occur in hospital. Once people get to hospital with their asthma, we're quite good at managing them with their nebulizers and their oral steroids and their, if necessary, ventilating. They occur in the community, where the severity of their asthma symptoms is not recognized either by the patient themselves, most commonly, or by the clinicians looking after them. And we can see from this graph that the people who overuse SABA are more likely to die from asthma. And this graph shows people who, the bottom line shows people who are using more than 11 SABAs a year. So they're basically getting through one blue inhaler every month. So overuse of salbutamol is a marker of poor asthma control, and it suggests that they're not using their preventative medications that could save their lives. So when they did the National Review of Asthma Deaths in 2014, they were able to see that of the patients who died in the previous year, around 39% of them had been getting one SABA every month at least. Now, if you look at the whole population of asthmatics, that's a small proportion of the asthmatics who get one salbutamol inhaler a month, but clearly they have a high mortality rate. And alongside that, a large proportion of these people who die are getting fewer than 4 preventative inhalers a year. So that's very important too. Now, across the southwest of England, mortality rates from asthma are relatively low, because in fact the prevalence of asthma in the southwest is relatively high compared to the rest of England. So in most of the ICBs in the southwest, it's relatively low, except for Dorset, where up to 2019, where this data goes up to, the mortality rates were actually worse than the national average. And that's been something that's been bothering me for a number of years. And so these new guidelines are a real opportunity. So these new guidelines emphasize the fact that asthma deaths occur because of uncontrolled airway inflammation. They don't occur due to lack of salbutamol. It's the adherence to inhaled steroids that is key in controlling asthma and preventing the deteriorations that put their lives at risk. And you can see that the identifying people who are at risk of poor outcomes include looking for those people who don't adhere to their their preventative treatments and instead rely on their blue inhaler, and therefore are people who come in and out of hospital or come in and out of A&E or go and see their GP an awful lot. And one of the key messages is do not prescribe short-acting beta-2 agonists to people of any age with asthma without giving them an inhaled corticosteroid. So nobody should be on a blue inhaler alone for asthma. Currently, in Dorset, around 6% of our asthmatics are on just salbutamol. But they are still people who have exacerbations, and they're still people who come into hospital. So that is a very key message. We know that inhaled steroids are important, not just to prevent deaths, but also preventing admissions to hospital. So this is the admission rates across the 7 integrated care boards in the southwest of England. And we can see that those integrated care boards where compliance with inhaled steroids is better, Cornwall and Somerset, their admission rates are lower compared to, for example, BNSSG around Bristol, where compliance is much worse. And the rest of us are somewhere in the middle. And actually, we can see similar data reflected across the primary care networks of Dorset, where seems to be a correlation. These primary care networks have got fewer exacerbation rates about almost a quarter of the areas where their compliance with inhaled steroids is worse. These people have much better compliance with inhaled steroids than these primary care networks. So if every primary care network was as good as this one, which is Sherborne, there'd be 72% fewer asthma admissions across Dorset. So what can we do? Well, basically, the message from the NICE guidelines: no more salbutamol in a blue inhaler. Instead, what we should be doing is using ICS formoterol inhalers, so inhalers that contain an inhaled steroid, but also contain a long-acting bronchodilator called formoterol. Formoterol is a very good bronchodilator, and it works very quickly. It works as quickly as salbutamol, and therefore can be used as the reliever as well as a preventer. And if they use their reliever and it's got ICS into it, then they will be getting a bit more steroid, and it can prevent the exacerbation getting any worse. As they increase their reliever dose, they get more steroid on board. And we have 4 inhalers here which could be used for this. The one inhaler that has the license for this approach for what we call the AIR regime is Symbicort. So Symbicort has the license to be used on its own as solely a reliever. The Foster and the Fobumix inhalers have a license to be used as maintenance and reliever treatment, but don't have a license to be used not as maintenance, just simply as reliever. But I think that's in Dorset we're relatively relaxed about the fact that all these inhalers probably have a generic effect, whether they've got a license or not, in being useful, even if we only use them intermittently. So this is formoterol. This is the effect of bronchodilation effects of Foster compared to seretide. Salmeterol is a much slower acting bronchodilator and therefore isn't appropriate to use seretide in this way. But Foster and other inhalers containing formoterol can be used as preventers and relievers. This is the evidence base. This is the study that shows, one of them, several studies that shows this. And basically what they've done here, they've compared ICS formoterol for mild asthma. They firstly compared it with as required SABA, so people who are just on a blue inhaler, and they give them this inhaler instead. And this graph shows that the exacerbation rate is much lower over a period of a year. So the exacerbation rate was much higher with just a blue inhaler they used terbutaline in this case, but it would be the same with salbutamol. When compared this regime to just regular inhaled steroids, so taking your Qvar or your Clenil, 2 puffs twice a day with a blue inhaler on top of it, the exacerbation rates were the same. And this shows severe exacerbations. That means ones that are admitted to hospital. This shows moderate and severe exacerbations. So one of the other findings, though, was in this group here, if you compared the people using regular inhaled steroids, they used much more inhaled steroid than if they just had the ICS formoterol inhaler used as required. So you got just as good asthma control, but at a much lower dose of inhaled steroid. And therefore, the potential for side effects from the inhaled steroids should be lower. And this, there have been a number of studies done on this, and they did a Cochrane review in 2021. This is the comparison of this. So this is out of 1,000 patients treated using this regime. If you compare it with SABA alone, these people will not have an exacerbation if you give them this new regime with the ICS formoterol inhaler compared with SABA alone. So admission rates, ED visits reduced by 65%. So that's quite a profound effect. And even if you compare it with this now with much a larger study with more patients, it's become clear that even if you compare it with regular inhaled steroids, the exacerbation rate is less with this regime than with regular inhaled steroids. Exacerbation rates reduced by 21%, and with less than half the amount of inhaled steroids. So less medication, better effect, because we're using it when the patient needs it. So what should we do when we see the patients? Well, what we're talking about here is people with mild asthma, so intermittent symptoms. What we're suggesting is we use this thing called AIR, anti-inflammatory reliever therapy. And that's where you just have this pink inhaler or red inhaler, which contains inhaled steroid, that you just use as required. As their symptoms become more significant, if their asthma is more severe, then they may need regular treatment. And this is what we call the MART regime, maintenance and reliever therapy. So that's where you have your inhaler and you use it regularly. And it could be done 1 puff twice a day, plus as required, or 2 puffs twice a day, plus as required. And that's what we call low dose and moderate dose MART. So it's this stepwise approach, and people, as their asthma comes under control, they're going to be moving more in this direction to just using their inhaler as required, and then as they become more symptomatic, they'll move automatically, as they're using it more, to a more MART regime. So they'll move from AIR to MART and back again. And the inhalers that we can use, well, as I said, the only inhaler that's got a license for AIR and MART is the Symbicort 200 inhaler, and you can use that up to 12 puffs per day. But a lot of our patients aren't used to using dry powder inhalers and would prefer probably to stick to the usual metered dose inhaler, the squirty ones. And so the Foster MDI contains formoterol, contains a different molecule for the steroid, it contains beclomethasone, and it has a license for MART use. If we're going to use it for AIR, it is using it off license, but it's likely that the benefit of AIR is a generic effect for any inhaled steroid containing inhaler which has got formoterol in it. And so in Dorset, we're happy for people to use that as part of the AIR regime. And the up to 8 puffs a day can be taken of Foster. So if you're using on the MART regime, you could take 2 puffs twice a day plus 4 more. There are alternative dry powder inhalers, the Foster Next Haler. Once again, that doesn't have a license for AIR. And there's Fobumix as well, which has got a license for MART, but for AIR would be off license. You can use up to 12 puffs of that a day. What you can't do is use these other inhalers, like Relvar, which has got a much slower acting bronchodilator in it, or Seretide, which has got salmeterol. And these triple inhalers, which have got long-acting anticholinergics, those can't be used as part of this AIR or MART regimes, because you can't modify the dose. They're a fixed dose inhaler, so you can't use those as your reliever. So we're going to see a shift of us asthmatic patients, not COPD, this is just for asthma, towards using these formoterol containing inhalers and using them as their reliever as well as their maintenance treatment. Now, if their asthma isn't controlled with moderate dose MART, then we can add in those other medications, the montelukast that we currently use, the long-acting anticholinergics in a separate inhaler, so that would be the one that would have the license would be the tiotropium respimat inhaler, and then biologics. So for eosinophilic asthma, biologics are very effective at reducing exacerbations. There are still going to be some patients who will be on the traditional approach of moderate dose, low dose inhaled steroids with a salbutamol, but we're hoping that over time those are going to be phased out. So when people are newly diagnosed with asthma, we want them to go straight onto one of these AIR or MART regimes rather than going onto the traditional approach. And there are still going to be people on fixed dose triple therapy who've got more severe asthma, which may be Trimbo at 87 or the double strength one at 172 micrograms. So those are the options. So the message for the emergency department is when you see a patient with an asthma exacerbation, you do what you normally would do, but don't give them a blue inhaler. So assess them using a peak flow. Peak flow is crucial, really, especially if this is a new diagnosis of asthma, because what you're wanting to do is to assess the response. How much is that peak flow improving? And so using a peak flow is crucial to assess the severity of the condition as well as achieving a diagnosis early on. And then give them an inhaled steroid formoterol inhaler, such as Foster, and if they've already got one, get them to use it, and they can have up to 8 puffs over the 24-hour period. But if that's not enough for them, then offer them salbutamol via the nebulizer, but don't offer them a blue inhaler. Also, as usual, prescribe and administer prednisolone 40 milligrams or so, perhaps a little higher if they're got a high BMI. And if they've improved and there's no need for admission, the peak flow is improved, then discuss the potential triggers as you would normally do. Make sure they've had some smoking cessation advice and potentially a referral, and provide them with an ICS formoterol inhaler as preventer and reliever. If they've come with an exacerbation, they're going to need to take it regularly as part of the MART regime to start with, in order to damp down that inflammation going on in their airways. But don't give them a salbutamol inhaler to take them away, because otherwise they'll just end up getting into bad habits with a blue inhaler. As their asthma gets under control again, they may then reduce their inhaled steroid dose and just use the AIR regime as required. And then don't forget to arrange follow-up in the community or in the hospital. So there are asthma nurses in the community who you can link in with, and we'll provide you with email addresses so you can contact those. But within the hospital, we also have asthma nurses who can review the patients in the hospital, especially those with more significant exacerbations or recurrent exacerbations. And if necessary, if there's a diagnostic doubt, then they can be referred to a respiratory consultant. So, a big change. Blue inhalers are out. these ICS formoterol containing inhalers are in for relieving as well as preventing asthma exacerbations. Thank you.